Well, here we are. So, welcome everybody. This is Barry Sarvet here, and I'm the statewide medical director for MCPAP. And it's always a pleasure for me to get us kicked off, get us started with our clinical conversations. And I'm expecting this is going to be a really good session. So, thanks for coming. So as you know, it's the fourth Tuesday of the month, and so this particular month we actually were late in deciding this because we had a glitch with the topic that we had planned to talk about, which I announced last time, which was on sexually reactive behavior in children, and so we're gonna do that probably in the next cycle starting in the fall. But today we actually decided to add in a topic that we did not originally anticipate for the year, which is on educational accommodations for children with psychiatric disabilities, particularly 504 plans. And that's actually the topic that came up last month when we were talking about IEPs, and it became clear that there's a lot of need for services for kids who don't qualify for an IEP, on the basis of their psychiatric illness. And so we thought we would sort of have an extra session and really focus specifically on 504 plans and other pathways for getting special education support or special accommodations for kids to help support their education when they're struggling with psychiatric illness, and the role of primary care providers to sort of advocate for kids to have these kinds of services. So this is going to be our topic for today. And next month, just as a teaser, we have Dr. Bruce Waslick, who is going to give us a talk on ARFID, particularly the avoidant restrictive food intake disorder. And so that invitation will be coming up. So just as a matter of housekeeping, before we get started, we are going to be offering CME as usual, and the code is forthcoming. That we don't have it quite yet, but we will have it shortly, and we'll put it in the chat. As always, we record the sessions, with the permission of our speaker, of course, and we will have it available on the MCPAP website after the talk. And our speaker is also going to be providing us a copy of her slides, which will also be posted on the MCPAP website. As usual, we encourage Q&A and liberally just put them into the chat. As you think of questions, just feel free to put them up, and we'll address them either at the time we see them, if that's kind of relevant to what is being talked about, and if not, then we'll address them at the end. But we love your questions, and last time we had some really nice discussion, and so hopefully we'll have that again this month too. And so at the end, just a reminder, if you could feel free to, or just please, make the effort to fill out a quick survey that you'll be notified about, and that we really need the feedback. So before we get started, our speaker today is a lovely, wonderful person named Mary Beth Landy, who is a family education advocate. And she has 20 years of experience as a family and educational advocate, trying to help develop special education plans and advocate for kids to get services. And she's been doing this for 20 years, and works as the volunteer recruitment and engagement manager at the Federation for Families with Children with Special Needs. And she works as the call center coordinator at that organization, assessing and assisting families and professionals by educating, informing, and empowering them in special education rights and services. She really is very knowledgeable about the legislation, that is relevant to this area, at both the federal and state level, and has also worked as a senior trainer for trauma and support services as well. So Mary Beth has also run her own educational advocacy agency specializing in mental health issues. She's been a trainer and facilitator for the National Alliance for Mental Illness, NAMI, in Massachusetts, and a family partner for Riverside Community Care. She also has lived experience. She is the parent of two children adopted through the Department of Children and Families and a stepdaughter, all having mental health and developmental childhood trauma issues. And she serves on the leadership committee of the Family Advisory Committee for the Department of Children and Families in Massachusetts. So with that, I'm going to hand over to Mary Beth, and we're going to proceed with this topic. But thank you again.
Great, thank you, Barry. I am going to share my slides. So you give me 1 second. Okay, so I have, like I said, been doing special education for over 20 years. I will clarify 504s are not special education, and we're going to go through the differences between the two of them. But there's no need for me to introduce myself now that Barry has done that. So I do appreciate that, Barry. But we want to look at what the accommodations are that physicians can be asking for or requesting in or recommending, depending on the terminology, that can be asking for with children with mental health issues. It is something that I specialize in because of my own lived experience with my children, but I also believe that it's what I call the non-carceral disorders. When your child is in the hospital because they are having emergency surgery, everybody comes with casseroles to your house, and when your child's in the psych hospital, nobody shows up. So it is challenging. It is also challenging to be able to get services at school for children with mental health issues, primarily because it's not something that schools understand very well. It's also not something that may present itself in a way that the parents are seeing it at home. So there's a lot of pushback in that, particularly if the child is good at masking. I have my 17-year-old stepdaughter is perfect at masking, so everything's fine, which I don't accept that as an answer anymore because of that. Everything is usually not fine and not okay. And in fact, as I was discussing with the team here, she is in a partial hospitalization right now. So, but she is fine. So anyway, let me, I just need to pull up my, there we go. So we're going to talk about what a 504 is versus an IEP that falls under the Individual with Disabilities Education Act, how to request the 504 plan, what's in it, and then we're going to go through the accommodations. What are some general accommodations that can be asked for regardless of the diagnosis, versus what are some specific accommodations applied to specific diagnosis. And then we will go through and I'll provide you some resources. So just to clarify, as I said before, the 504 is not special education. It is actually part of the, it is referred to as 504 because of the Section 504 of the Rehabilitation Act. So anyone can have a 504 plan. It does not exist just in education. I have one for work because of a variety of issues. I have dyslexia, for example, so work pays for my ink and my paper for my printer because I don't read well on long articles on my computer, so I can print them off, that sort of thing. So 504s are also for students who may be on an IEP, but when they graduate from high school, the IEP no longer exists, and they need to turn that into a 504 in order to get accommodations and modifications in college, or their secondary career, whatever that might be. So we want to make sure that the law and the 504 protects people who have a disability, so that they cannot be excluded from participating in or denied benefits or discriminated because of their disability. So the difference between the two is they both have to fit within the disability category. And so for 504, that can be physical or mental impairment. And under IDEA, it has to fit into the specific categories that the federal government has determined are categories for an IEP. It must substantially limit the major life activities and the need for accommodations in order or related services in order to be able to level the playing field for individuals that are struggling with a psychiatric disability. So anybody who falls under this category, they have a mental impairment which substantially eliminates one or more major life activities, a record of such impairment, which you are providing by diagnosing it and recording the diagnosis, then they are regarded as having such impairment. And every citation that you see listed is either from the state or the federal government. This happens to be from the federal government. So I will also be sending you resources that you can refer to if you're looking for more in-depth information about it. So we're going to talk about certain diagnoses today based on my conversation with Barry. I do want to clarify that attention deficit hyperactivity disorder is actually a health impairment. It is not considered a mental health impairment. It falls under the category of health, and autism also falls under its own category. So they actually are not considered mental health disabilities or emotional disturbances by the federal government. So just so you're aware of that. And certainly for autism, there is a completely different set of questions that are asked as part of the process of evaluation so that the student can, if they have the diagnosis of autism, can get secondary services and supports that may not be provided for somebody, say, with anxiety, such as a communication device. So those are the categories we're going to cover. That is obviously not all of them, but those are the ones I've been asked to speak to today. So what does substantial limit mean? There's actually no litmus test for what applies for a substantial limitation. It is something that depends on the student, but it needs to for IEP. I'm sorry, for 504 purposes for academics, it actually needs to impact the student in the school. And one thing we want to make sure is that whatever activities that it limits, it is not a consideration of just the student's grades, because we want to look at the whole life of the school. So we want to look at the student not just as how are they doing academically, but also how are they doing on the playground? Are they able to make friends? Do they have difficulty? Is there bullying going on that may be part of their impairment? So we want to take a look at that. What is the nature of it, the severity of it, and the expected length of impairment that may affect the individual at the time. So there are certain things that, and one thing I want to caveat I want to say is that if an additional diagnosis or clarification of a diagnosis is made by a physician, that requires the team to come back together and reevaluate the situation. So even if a student has a diagnosis of anxiety, but then is diagnosed with ADHD, the team is required to reconvene in order to be able to take a look at how does that impairment complicate and the comorbidity of that overlap with the initial diagnosis. So one of the things that's required in order to determine whether a student is eligible for a 504 plan are evaluations. So anybody can refer a child for evaluations. Anybody who is concerned about and knowledgeable about the child can do that. So it can be a teacher, which it should be at school. Many times teachers will call parents and inform them that something's just a little off, or that the student is struggling in certain areas. Sometimes that comes up in conversation, and a teacher might say that they seem to have no friends at school. Those are things that parents want to keep their ears open for, to see if there's something that can be done by the school to be able to rectify that. And those social and emotional situations are part of the life of the school. So it is the school's responsibility to be able to meet those needs of the student. That is not something that is just left to the parents or home situation to be able to rectify. The evaluations must be done by a trained professional, completed in a reasonable amount of time, which actually is the same amount of time that would have to happen for an IEP, which is 45 days. In Evaluate in all areas of educational need, not just what the student's IQ is. For mental health diagnosis, a diagnosis is not required for either an IEP or 504. Just so that you're aware of that. That is the only category that a specific diagnosis does not have to be made in order for a child to be eligible for a 504 or an IEP. Parent consent is required in order to do testing, and then there must be reevaluation, so that it is important that a parent sign off on those evaluations so that we can continue to come back to the table to have discussions. There is not, however, the provision with a 504 to ask for an independent evaluation at the school's extent. That is special education, and that falls under the an IEP if that is what parents are seeking. So just basically, we're looking at services and school placement. These should be in the general education classroom, in a classroom with supplementary services if necessary. And the difference with an IEP would be that there is special education instruction being given, but related services are available through a 504. Students need to be replaced in the least restrictive environment for the maximum extent possible. So if the student is not having academic challenges because of their diagnosis, they are allowed to be in the general ed classroom for as long as they can handle being in the general ed classroom. And we'll look at modifications if the student needs to be pulled out or have an alternative setting, such as a learning center, so that they can step out and have, or a sensory room, something that where they can step out and have a calming space, or a space where they are not so pressured as it might be in the general education classroom. So these are some examples of accommodations for 504 for anyone, but just they're very general. So obviously removal of physical barriers, such as wheelchair ramps, things like that for someone with a physical disability, but extended time for testing, adjustment to class schedule, which is a modification. So they may be allowed to come in later for school, or they may be allowed to leave earlier if they are having difficulty remaining in the classroom at school. So those are possible adjustments to the school schedule. Rest periods, break periods that they can take in for a student with autism may need a sensory break and need to go to a sensory room. So it really depends. This is very individualized. So it is something that we want to take a look at, not just these general ones, but we're going to look a little bit more at some of the diagnosis and what are some recommendations. And there's a lot of overlap for these recommendations. So it is not, there are some that are more specific to particular diagnosis, and then there are other ones that apply to any of these particular diagnoses. Um, so for a child who's struggling with depression, one of the most important aspects of supports are emotional and attendance supports. A lot of children have difficulty with attendance at school, and the difficulty is that school is trying to get, 180 days in. That's the requirement in the state of Massachusetts. Having absences creates a difficulty for them because the student's not accessing the curriculum if they're not in class, and therefore they're not providing the education services that they need to be doing. So there may be allowing for late arrivals, early dismissals, or absences for therapy appointments, medical appointments. It is uh, difficult to be able to find, particularly in the Western Mass area, it's difficult to be able to find a therapist, let alone a therapist that can accommodate all the kids after school. So there are times that kids have to be pulled out of school in order to attend therapy or medical appointments. And the school needs to allow for that. If it is a regular appointment, like a therapy appointment every week, that should be written on the 504 so that there's no question about whether in fact it's coming up, or this teacher can figure out a schedule working around so they're not always missing possibly the same class every single week, and how to accommodate for that. Designated check-ins, establishing check-ins with the school counselor or a designated safe adult on campus, and safe space access. Allowing a student to be able to have access to, say, the wellness center or a calm down room, and I don't mean a timeout room, a room that's a sensory room that they can, when they're struggling with um, heavy symptoms, that they can go to a room where it is sensory driven, quiet, different lighting, so that they can calm themselves and learn to regulate themselves. Accommodations for testing, extended time. There is limits to extended time, so it's not just the student has all the time in the world. Usually most schools offer a time and a half. Some will allow for double time. The question comes up when that's done, when is the student allowed to take that time and a half? Sometimes it's taking the allotted test time during class and then coming back at lunchtime to do the additional time, or after school. So you need to work out the details with that, so that they're not missing another class in order to do their extended time. Alternative environments. The low distraction room that I was just talking about with reduced pressure. Sometimes it's the learning center where there's somebody there that can assist them and kind of keep them focused on what they're doing. Be able to do some flexible scheduling, taking tests in chunks as opposed to taking tests all in one sitting. And also classroom flexibility, modifying deadlines, sometimes reducing caseloads, or course loads, depending on the student's need and what they plan on attending when they get older. Maybe there is the need for the student to be able to have, for example, if they're going to have counseling, they need to schedule that in. It may be that the student doesn't take a second language, so that they have time to be able to do these things, to go to the learning center, to be able to go to counseling. particularly depending on how many times it is within their schedule. The reduced course load can also be looking for quality over quantity, so that the student is not required to do, if there's 20 math problems on a page, they're not required to do all 20 of them and figure the whole page out, but maybe they can do the first 5. And as long as they're showing proficiency in that, then that is acceptable. They're graded on the work they do, not on the quantity of the work that they do. Preferential seating. This is interesting because usually preferential seating, most people think that this means that they should be sitting up next to the teacher. And that's not always the case, as we'll talk about when we get to PTSD and anxiety, is that sitting up next to the teacher can sometimes be challenging. As Barry mentioned, I have 2 kids that were adopted through DCF with severe trauma. And preferential seating for them was not the front of the classroom because, as they said, every time a pencil dropped or somebody coughed or anything, they were always turning around to see what was happening behind them, which was taking their focus away from the teacher, which was the whole point of the preferential seating. Their preferential seating was actually at the back of the classroom with their back up against the wall, so there's nobody behind them, and that they can see the windows and doors. So it provided them with a sense of safety, and they can see what was happening in the classroom without having to turn around and take their attention off of what was happening at the front of the classroom. Recorded lectures many times, or notes, class notes, can help with a student who has struggled with brain fog, as we call it, or fatigue. A lot of students, particularly students with either trauma or anxiety, as you know, have higher levels of cortisol, and that affects their ability to get a sound sleep. And so therefore you may have kids in the classroom who seem distracted because they're exhausted. So that can be an accommodation that you're looking at. For anxiety, calm spaces, kind of like the picture, which is an alternative setting where they can remain in the classroom so they can still hear the teacher. It may have a different type of seating so that they can be comfortable, or maybe it's a sensory seating so that they sit on a bouncy ball. So it gives them the ability, or yoga ball, to be able to give them the ability to flex and move so that they can take the energy that's built up within them and put that into what they're doing. It allows them to set that aside and be able to focus on the task at hand in the classroom. Sensory tools. It should be very clear to be stated in any recommendation that they are sensory tools and not fidget toys. Toys are not permissible in class, so it needs to be considered a tool that the student would actually use, and one that is not distracting to other students. I have several of them on my desk. I use them for long meetings. There's one right there. So it is something that it just can't make a lot of noise. It can't shoot off things, shooting rubber bands. They can have a rubber band on their wrist that they snap, but they can't shoot rubber bands. So the use of them should be done in conjunction with an occupational therapist. We talked a little about testing modifications. Testing can be done in a smaller setting with a preferred proctor. So it could be somebody they know that they're comfortable with. And it may be that it's just them, or it may be them and a couple of other students. So it's a quiet, focused setting. Alternative ways to submit projects or papers that they're working on, rather than just taking a test, they could possibly do a conversation or oral test with the teacher to demonstrate their competency. They can do an art project. They can do a PowerPoint slide presentation. It all depends on what the student's island of competency is, what they are good at, and how to be able to take those preferences and interests and turn them into accessible tools that they can use to be able to submit their knowledge to a teacher without having to go through, particularly if they have test anxiety.
Hey, Mary Beth.
Yes.
Yeah, I don't want to slow you down too much because I know that you're getting this is really important material, and but I did want to bring up just in the context of anxiety, particularly, that a lot of times, the standard accommodation plans are sort of meant to try to help kids to feel, more comfortable, right?
Mm-hmm.
Not to have to deal with, as much anxiety. Um, and that's good. On the other hand, a lot of kids, get into trouble with too much avoidance. That's kind of a main, issue and challenge for kids with anxiety is that they don't want to participate in certain things and then they lose the ability to participate because they haven't had as much experience and that's kind of part of the, outcomes, associated with anxiety disorders. And so sometimes our plans have to do with like working collaboratively with the school to really push kids, and to kind of, to really encourage them to participate as opposed to giving them avenues for being able to opt out.
Mm-hmm.
And so I wonder if like how much can we sort of ask the school to, sort of help us with that kind of nuance in the sense that we want them to be comfortable, but we also want them to be pushed, and to have sort of a plan to be able to kind of maintain participation, as best
Mm-hmm.
that they can and things that make them nervous. Yeah, what do you think?
Absolutely. I have a phrase that I use in that avenue is compassionate accountability. So meeting the student where they're at and their level of anxiety, but also still holding them accountable for the work that they need to do. So a lot of times, a lot of our kids are frequent flyers to the nurse's office or to the counselor's office, um, and particularly around non-preferred activities. So there's nothing wrong with being empathetic towards that and with their anxiety, but there's also things that can be done like setting up time. You can take, 3 minutes and walk to the water fountain to get some water to take a break, but there's a timeline that's set on it. So,
Right.
and then return back to the classroom. If they're going to the nurse's office and they always seem to go during math, um, you know, letting them go to the nurse's office, but they have to take their work with them. So they have to complete it in an alternative setting. It just lowers their threshold of anxiety so that they can access their cortex and be able to do the work. So, still holding them accountable for doing it, and then also trying to, as with anything, decrease the amount of times that they're going to an alternative setting and also increase the frequency of being able to stay in the classroom. So maybe the question is, of can I go see the nurse?
Yeah, yeah,
Is let's finish this problem or this worksheet, and then we'll talk about it.
yeah. That's great. That's great. And just, sort of taking it back to like what the PCP is supposed to do, in this equation, right? What I usually recommend, and I'm wondering like if you agree, is for PCPs to write a letter, sort of, identifying some of these needs,
Hmm.
but mainly sort of encourage, recommending to the school that they work, as a matter of process with the child's therapist to
Hmm.
kind of devise, these kinds of plans. Because I think a lot of times, like these plans, need to be kind of, really married to where a child is in their treatment, in
Right.
their therapy, like what they're working on, and to have the school sort of experience be kind of aligned, with that work. And so So I was just curious about like the process, is it, so I recommend that they do the planning with the therapist around that kind of
Absolutely.
stuff, and I don't always know what the process, is going to be for that kind of collaboration, but I just know that I want it to happen, the
Yeah.
collaboration. Yeah, yeah.
And usually the collaboration can be easily arranged. Well, not easily because of everyone's schedule, but should be arranged, and the school should be working with the individual therapist. They should be in conjunction with the adjustment counselor at school, so that they're working on the same. They may be using different methods, but they're working on the
Mhm.
same issues and concerns. Um, I know just from lived experience with my stepdaughter, her adjustment counselor at school and her therapist would speak on a weekly basis as far
Mhm.
as what was happening, and also would talk about the avoidance. Um, the
Mhm.
phone calls from the bathroom were really frequent of "come get me."
Mhm.
So, to try and avoid that, how could that would be a discussion in therapy, and they would work out together what was a good plan, not just a safety plan, but what was an action plan, is what we called it for in school, to be able to keep her from avoiding the non-preferred activities.
Yes, that's great. Thank you very much, Mary Beth.
Yeah.
And to this point, I think it's just a reflection of this being challenging. As one of the doctors in the chat said that they often get requests from college students who want a single room. And I think that's just a perfect example of the kinds of sort of nuances that you have to think about, with these things,
Hmm.
because like some of these college students, the last thing that they really need is a single room. That
Right.
we know they want one. And sometimes they really do need a single room because it would be too overwhelming for them to be on campus, with a roommate, and they're just not ready for being exposed at that level to that sort of social, experience.
Right.
So it just requires collaboration. That it's not like a formulaic thing, that these 504 plans have to be married to, where people are at in their treatment but it comes down oftentimes for the PCP, it comes down to a binary decision. Do I say yes or no to what's being requested? And the answer is sometimes you have to say yes, sometimes you say no, and it's best to try to decide that in collaboration with a therapist who knows what the person's working on and
Hmm.
what they're ready for. Yeah,
Yep.
yeah.
And that therapist also may be someone in disability services for the student, for a college student. As far as a student may want to be able to have additional time for tests. And the one difference with a 504 in college is that the student must disclose themselves that they have a disability to every professor, and every professor and the student will work out together for that particular class. What are the accommodations that they are willing to, or that work within that class?
Mhm.
So, if you're a biology student and you don't want to do lab because there's too many people in there, that makes it's a little challenging to take that course load. So, and that's where communication comes in, is really working at what is the student's need and what is their capacity at that time.
Right. Absolutely.
Yep.
Thank you, Mariette. Sorry I
No,
slowed you
please
down.
do.
Yeah, yeah, yeah.
Please do. So I want to take a look at ADHD and ODD. So there are executive functioning and focus is really a primary aspect of you'll find an attention deficit hyperactive disorder. So what is the environment? So maybe the environment, as the picture indicates, is a space within the classroom, but that has limited distractions. Because if you just look at the picture, the wall is distracting enough. So it may be something where um, the student is has there's a separate quiet space, so there may be a separate table that is in an area that's not so distracting, with a bookshelf, blocking They can still hear the teacher, they can still see the teacher, but it's not giving them access to maybe seeing outside, which can be very distracting. Um, Again, assignments and presentation, things to keep them focused. A lot of kids with ADHD also have sensory issues, so they need to have something that they can do, working with some fidget tools, something like that, that can allow them to be able to work off some of that extra um, adrenaline that they have in their systems. And behavioral and emotion regulation is so huge for kids with oppositional defiant disorder. Routines is important. As much as every kid says that they hate routine and structure, they really thrive on it. And that is something that is helps so much with emotion regulation, even for a child with anxiety. I tell teachers all the time when I train them, if you know you're going to be out for a doctor's appointment or a dentist appointment on Thursday, let the class know that there'll be a substitute, because it's going to lower the anxiety for the children so that they are not thrown when a substitute comes in, because it will be a horrible day for both the teacher and for the child if they have difficulty with that. So, um, communication with parents, sending a notice home to let them know as well of what's happening in the classroom and how things are working. Um, Really, this is a good time for a functional behavioral assessment possibly to be done within the school by a behavioralist to take a look and seeing what is happening in the classroom, what is the antecedent that's happening, particularly before behavioral manifestations. So is the child in a situation that is just too overwhelming for them and they don't know how to regulate that? So there are many steps that can be taken as far as behavioral plan uh, in conjunction with the 504 to be able to address some of those issues for the student. Um, so I am kind of going through these fast, so we can definitely backtrack on anything. I just want to make sure that I get through all of them, and then we have time to be able to come back to this. So for autism, I think that all the above applies, but I think for autism, we really need to look at the sensory issues. Um, uh, is the child have do they have access to headphones or earplugs during loud activities? Um, you know, the elementary school cafeterias are the most deafening experiences I've ever been through. Just walking through with 200 kids yelling because they're all have to yell to hear over the next person. Possibly noise canceling headphones or earplugs during those moments, or during a school assembly. Like I said, the sensory tools are something that they should have access to. Not an unlimited amount, but ones that'll work for them and don't create a problem for the rest of the class. Adjusting lighting. I know many teachers have a sensory corner, at least where they can have alternative lighting sources, like a table lamp instead of the fluorescent lighting, so that fluorescent lighting actually impacts, particularly even not just kids with autism, but also kids with ADHD. It makes it difficulty for them to focus. So finding a space where they have a um, calming space so that they can recenter themselves or ground themselves is so important for kids with autism. But again, autism is a separate diagnosis, so from a mental health diagnosis. So there are accommodations and other things that are allowed for a student with autism. And that is very independent, with whatever their level of capabilities are, as to whether there's an intellectual disability along with that. So post-traumatic stress disorder. I actually am a specialist in developmental childhood trauma. So that's a term I prefer to use versus PTSD for students who may have been raised in environment that has created some traumatic stress for them. Like I said, the preferential seating is not necessarily where we think it might be. Safety is the biggest thing that I can really stress, is anything that will create a sense of safety for the student, and understanding, again, what the behavior may be that they are trying to avoid. Very often, what is the trigger for them that is coming up? If it is, uh, I worked with a student one time that they had to change the classroom for the student because the window, that the way the seats were seated in the classroom, it faced a window that overlooked an apartment house that this girl used to live in that had caught on fire, and she lost her younger brother in the process of the fire. So every time she sat in that classroom, she was dysregulated. But that was not something that was obvious to anybody until we really did some investigating and taking a look at where her triggers were coming from. And she wasn't able to access that to be able to tell us what was happening. So being able to do some behavioral assessments and take a look at what some of the problems for the student have been and how are they manifesting in their everyday life at this present moment. And some of those you just can't plan for. But having the staff available to be able to be at the nurse, my kids had a really close relationship with their nurse, their adjustment counselor, um, uh, anybody at school who they considered a safe person that they had access to. Again, not as a way to avoid what they're struggling with, but as a way to be able to ground themselves, feel centered. Because if they're not feeling that sense of safety, they're not going to be able to access the portions of the prefrontal cortex and things of the brain that will allow them to be able to access the curriculum. So they're basically kind of a ticking clock, just waiting for the alarm to go off and set them off. So that's, safety is so primary with the traumatic stress disorder. Psychosis, I think, is probably so misunderstood by schools that they're probably more likely, in my experience, to feel that the student needs to be hospitalized or in a hospital setting as opposed to in a classroom setting, particularly a gen ed classroom setting. So I think the communication is huge for a student who has psychosis, and whether they are in an episode at the time or not. We can't assume that a child is always in a psychotic episode. So it's important that there is constant communication between the school, the parents, and the therapist about what is happening, so that they have the ability to be able to access the life of the school. And many of these things are things that we've talked about, but we haven't talked yet about crisis planning and check-ins. And I think that that's something where a team, not just an individual, but a team really needs to sit down and figure out, in conjunction with the school counselor, of what is a safety plan for the school, how will it be implemented, what happens if the safe person is not in school that particular day. Everybody has a chance to have days off and have need not to be in school some days. So what are the safety and crisis intervention plans for the school setting, which may look different than one that's in the community or one at home. So it's important that we take a look at those. So I wanted to talk briefly about the individual healthcare plan, which can be used in Massachusetts to also help students who have mental health challenges. It is a school-based care plan for students with emotional needs for individual treatment or action plan. It can be managed through the state or your insurance company. depending on everybody has the right to ask for an individual case manager or an ICM, which would be someone who's kind of an advocate in your insurance company to help make sure that your child is getting the services, mental health services that they need. But they should also be part of the team that is crafting an individual healthcare plan. And this healthcare plan has to be implemented in the school to provide resources and things for long-term support for the student. Um, and it is something that is, I don't think it's well understood. I think that many, even advocates, aren't aware of the possibility of using this, so that it is a collaborative plan that is developed by the school, the community providers, as well as the family and the student, depending on what their age is. Because we want to make sure that we are working with a plan that the child that works for the child, and the child will actually utilize when necessary. It'll take care of looking for specific accommodations. Importantly, what are the symptoms to be looking for that the school needs to take action for? What happens if a student is having a panic attack or a behavioral crisis? It takes it one step beyond a behavioral plan. So we're real, or a safety plan. We're really taking a look community wise as to what can happen. What happens if the child is having a behavioral crisis, but the school is unable to get in touch with the parent, who's the next person that they should be contacting, who is a safe person that they can, if nothing else, have a phone conversation with. From my daughter, my stepdaughter, many times that would be the school adjustment counselor might reach out to the therapist and see if she was available to talk to her over the phone for 10 minutes or so, and kind of ground her so that we could try and regulate her so that she didn't have to be picked up from school and she could make it through the rest of the day at school, as we were talking about earlier. So just a couple of things as far as the 504. What if it's not being followed? So the 504 is actually it does not have to be in writing. So I just want to make sure people are aware of that. I always recommend to parents to get it in writing, because otherwise it becomes a he said, she said thing, and what happened after the meeting. So you're going to have a meeting with the school to try and resolve the issue. If that does not work, you can file a grievance. Every school has a Section 504 coordinator. This is not the special ed director. Many times it's the assistant principal. But somebody needs to have at the school needs to be responsible for the 504s and to make sure that they're prompt and equitable. You can request mediation from the state, or families can do that, where they sit down with the state mediator to try and come to an agreement and understanding, mutual understanding. If in fact it does not work, they can write a written request to have a hearing from the Board of Special Education Appeals. Even though this is a 504, they still have the right to do that. Because part of the question may be, maybe the 504 is not suitable enough for the student and they do need to have an IEP. That's one of the reasons why I went into advocating, is because there were not enough advocates that understood special education for children with mental health issues. So there's always filing a complaint with the Office of Civil Rights, which is an iffy thing right now. Just so you're aware, that's one of the offices that was dismantled by the administration. So there's no longer a Boston Office for Civil Rights. The office was shut down. There is one on the federal level. There is one individual working for the Department of Elementary and Secondary Education that handles all the civil rights complaints. So there's definitely a backlog, but the complaint needs to be filed within 180 days of violation. So there is a statutory limitation on that. And people have gone to such an extent as to file a federal lawsuit. So these are some resources. All of these are hyperlinks, which will be accessible to you when I send the PowerPoint. So you're certainly welcome to dig a little bit deeper into some of the law and things behind 504s. The Federation for Children with Special Needs has an information line where there are information specialists who can answer any questions that you might have about either special education or 504s, and as well as evaluators, and they have a plethora of information. So you can always either fill out a form or call the number, and they will get back to you within 48 hours. And that is that. So I want to open it up for discussion. I'm going to stop sharing my screen.
Thank you, Mary Beth, so much. And at this moment, there are no questions in the chat, but I thought I would, and we only have a few minutes left, and this was a very rich presentation. But I thought I would ask you just maybe in the last few minutes to talk about just the boundary, sort of between, healthcare providers and educators, because I kind of feel like that's one of the things that trips us up sometimes, that I find sometimes doctors, and providers will sort of, they won't aim their letter in the way that's most useful. That they might sort of be asking for things that are too specific and really kind of getting in the way of the fact that these plans really need to be constructed and designed by the school. And sometimes they don't ask for enough, because they don't feel like it's their place to say, what kids should, how they should be treated at school, and so what's the right level of specificity? My approach personally has been to identify with the goals, and to let the school be the one to come up with the, particular strategies. But sometimes I do propose strategies, as examples, but I also, pay my respect to the school to say, like, that you guys are the experts, and I would really appreciate you coming up with a plan to address these particular goals. But what do you think about that? Because it's sort of a boundary issue, I think, for me.
I think it is, it is important that it be a strong recommendation from, it does not have to be very overly specific, because of that pushback of schools will sometimes disregard the recommendations given by a physician because they feel there's a boundary issue.
Yeah, it's like their lane. It's not in their lane, as they
Right.
say. Yeah.
But there's also the importance that certain terminology not be used. And my recommendation is never use the phrase the student would benefit from, because the argument, that's a term that they will use to say, well, all students would benefit from that. We want to be specific in that this child needs, the necessity of the accommodations. But how it specifically plays out in the school and what the plan actually says, I think there's ways to be able to say these are the accommodations that are recommended, but I defer to the school staff to craft the accommodations so that they meet the needs of the student, but also the services the school is able to provide.
Yes, I think that's really nice, and I think that's a good place to end as well. But Mary Beth, thank you so much, and we really appreciate your willingness to share your slides, because I recommend to everybody in the audience that they download the slides and kind of keep them handy, because there's so much good content in the slides that kind of correspond to specific diagnoses, sort of give you ideas, for what you can be thinking about asking for, from the schools for your patients. And so I think this is going to be really good for everybody. But thank you again for the talk, Mary Beth, and
Of
thank you,
course.
the audience, for your presence and participation. And we'll look forward to seeing everybody next month.
Thank you for having me, and everyone have a great day.
Thank you.
Thank you, Barry.